Good afternoon. This is Dr. Eduardo de Marchena. I'm a professor of medicine at the University of Miami. I'm also the director of the Structural Heart Disease Training Program and the International Medicine Institute. And it's a great pleasure to have you here. In my other role as director of Miami Valves. Miami Valves is a conference now that's been going on for 6 years, following a tradition of 20 years of educational conferences in our interventional program. The Miami Valves Conference concentrates on structural heart disease, but it also does different sections on PCI, heart failure, electrophysiology, and even heart failure transplant. But the first 4 sessions are all structural heart disease, and this is the area which I'm going to be concentrating greatly on. We normally have Miami Valves in person, and in 2022, we expect to do that again. And we're going to be doing it on February 3rd to 5th of 2022 at the Marriott. So everybody can already start planning for that. I'll remind you again later. Because of how our world is, Miami Valves had to evolve. And this is Miami Valves in COVID era. So we are doing this virtual platform. We introduced it last week, and we talked about many of the people that are responsible for this being a successful conference. And but I'm going to waive that today because we have a very important agenda. I do want to mention that we have exhibitors. There's more exhibitors than this, but 3 of our exhibitors are Medtronic, Edwards Life Science, and Chasey USA Inc. 2 of them will be presenting a short exhibit at the end of our conference today, Medtronic and Edwards. There are multiple different programs that are being represented in this symposium. So I don't see Henry Ford there, but Henry Ford should be front and center because that's our group. And I always had to at least acknowledge the wonderful team that we have of structural heart disease and technicians, doctors, surgeons that help us make all these procedures successful. Now, today, we have a very special evening. We have an evening with Bill O'Neill, who is a person that really doesn't require much introduction to those of us that are in the field. Bill is an incredible human being. And I actually, last year, we recognized him in Miami Valves with a Lifetime Achievement Award. And so I wanted to say a few words about what we said then, to remind you a little bit about what Bill has done. So Bill, nearly all tools and techniques used from the very beginning of interventional cardiology and structural heart disease interventions have been touched and honed sharp by the creative visionary hand of Bill O'Neill. Just to name a few, he helped pioneer and prove the efficacy of PCI for the treatment of acute myocardial infarction. He then abdicated to make it a worldwide standard of care. In so doing, he has led to countless lives being saved and an uncountable number of patients spared the crippling morbidity of heart attack. He has studied and refined the care of cardiogenic shock. He led the investigation of the Impella device for cardiogenic shock and high-risk PCI, making it now a standard of care. He performed the first transcatheter aortic valve replacement in the United States and the first TAVR by retrograde technique in the world. He performed the first transcatheter aortic valve replacement in the US and has promoted the use of this technique for alternative access for TAVR. He has developed alcohol septal ablation as rescue and preventive technique of left ventricular outflow obstruction for the mitral valve and valve implantations, and it's being used now widely to prepare patients for the procedure when that sequela is expected. He has been a key investigator in a multitude of cardiac device trials. He has authored and co-authored several hundred peer-reviewed articles, abstracts, book chapters, edited one of the first textbooks in the field of interventional cardiology. His CV is over 100 pages long, and in PubMed, he has over 3,200 citations. He holds the title of Master for the Society of Cardiovascular Angiography and Intervention, among multiple awards, the prestigious Transcatheter Cardiovascular Therapeutics Lifetime Achievement Award, the Seymour Gordon Award for Distinguished Achievements from the American Heart Association, Michigan chapter, and of course, the most important one, the Miami Valves 2020 Lifetime Achievement Award. Previously, he was the Executive Dean of Clinical Affairs and Chief Medical Officer at the University of Miami Health System, where he helped propel our interventional structural program here. He was the Executive Dean of Research, Research Training, Innovative Medicine, CEO for Research, also at the University of Miami School of Medicine. Currently, he is the Director of the new Center for Structural Heart Disease at the Henry Ford Hospital, which is becoming one of the leading sites in the world for structural heart disease. Bill has done all of this and still maintained a tremendous level of humility and humanity. He is loved by his patients, peers, trainees, and staff. His upbeat, infectious energy stimulates productivity and excellence. Throughout his life, he's been a loyal and caring friend, loving father and husband. And I tell you, he is an exceptional human being in many, many ways. And we're lucky to have him tonight. So Bill, I'm going to stop sharing. If you could share your screen. And you have to unmute yourself.
Eddie, good evening. Can you hear me?
I can. Yes. Could you go on full? Can you go on full screen for on your PowerPoint?
How's that?
Presentation mode, if you can.
Presentation mode.
Dr. O'Neill, do you have two screens?
Yeah, I got two screens.
So if you go up where it says display settings on the top of the screen, and you swap the presenter view on a slideshow. Yeah, click there.
Oh my God, these wonderful guys. This is doing this slide sharing is more stressful than doing an acute MI cardiogenic shock, I gotta tell you, but it's wonderful to have these young superstars that can kind of figure this out. So thank you. It's a delight to be with you guys. And I want to start by a case, because I think this is kind of shows you where we are today in the field of structural heart disease. And we're basically treating patients that are so complex right now that I would have never thought, Eddie, that when we started in this field that we could ever treat such patients or that they could survive. So since this is a very case-based approach, I want to share this case with you. And then I have a short presentation and another new technique that I'm kind of working on. And you guys will be the first in the world to see kind of what's cooking in my mind and in our laboratory. So without further ado, let me tell you about this case. So this is a patient, 51 years old. So this guy, you have to go full stop to try to get him to survive. This is not a 100-year-old patient, but 51 years old. Tragically, he's had end-stage renal disease on hemodialysis. He's obese, and he presented with 48 hours of chest pain and worsening shortness of breath. He was at an outside hospital, a blood pressure of 80/30, ventricular paced. He had a grade 4/6 systolic murmur at the cardiac apex with a diastolic component. He had pulmonary rales on all lung fields. Patient has a history of a previous surgical aortic valve replacement with a root repair with a 23mm freestyle root in 2012. And so this now is obviously 10 years out, and it's about the time in which you're going to start expecting to see valve failure. His troponin was elevated, his BNP was elevated, his lactate was somewhat elevated. As I said, he's an AFib, and he's had a history of hypertension. So now this is what we see on the echo when he came into the emergency room, and you can see this ventricle is markedly dilated, and he's got wide open AI across the bioprosthetic valve. The valve itself is very stenotic, and so it's both a combination of aortic stenosis and probably a ruptured leaflet now causing severe massive aortic insufficiency. Now, if this guy wasn't unlucky enough, we also shot his coronary angiograms. And you can see here what's going on here. He's got a subtotal occlusion of the ostium of the LAD and a severe lesion of the circumflex artery. So we did his hemodynamics at the outside hospital. His RA pressure is 27, RV pressure is 74 over 18, PA pressure 75. His wedge is 44. It really was 44. In spite of that, he was actually able to sit, sort of lay semi-recumbent. He had a cardiac index of 0.9, and he had a pressure difference across the gradient of the valve of 25 millimeters, calculated aortic valve area 0.53, and a blood pressure of 80 over 30. He was in shock. They placed a balloon pump and then dobutamine and pressors and then transferred him. So I'm wondering, Eddie, maybe you guys and the wise folks over there, how do we treat this 51-year-old in cardiogenic shock with both severe prosthetic valve dysfunction and severe life-threatening multivessel coronary disease? Does this guy have any chance in terms of percutaneous approaches? Should we try to get him to surgery? Our surgeons are really reluctant to treat these kinds of patients because they're worried about their report card.
So, the first thing I would do is call Bill O'Neill, but no, I agree with you that it would be very difficult to get surgical for support for this type of case most of the time, even though we have superb cardiac surgery. I don't know, what do you guys otherwise think? I mean, we would probably try to do something with left ventricular support and then seeing if we can stabilize the patient, coronaries and valve in order, I suppose.
Eddie, I declare myself not on contest because I just sent Sergio a very similar case. And I can just tell a hint. He must have bicuspid valve because it's damaged. But did he have valve replacement? Does he have a
yeah, he's got a bioprosthetic valve that's 10 years old.
Possibly on the bicuspid.
Torn.
So I declare myself, I sent just this very similar case, biased by this case, okay. But I guess, what are you going to do?
Okay. Well, let me not hold you in suspense. Let's tell you where we started. Well, first of all, we are worried about mortality because we're publicly reported outcomes for our TAVR program. So we're extremely concerned about this. And we thought that we would try to stabilize him to see if he would survive. And then if we could get him to survive, then we'd go to plan 2, which was to revascularize him and then to treat his valve. And it's hard to know which order to go in, whether you vascularize and treat the valve or not. The other thing that I didn't tell you is that he's got a very low riding left coronary. So there is a very strong concern about left coronary obstruction on top of everything else. So these are the hemodynamics. His right atrial pressure is 22. His right ventricular pressure is 70 over 20, pulmonary artery pressure 70 over 44, and wedge of 38. Okay, so he's really in deep trouble. Blood pressure actually with the vasopressors was okay. This is the intra-aortic balloon pump support, which is kind of like whistling in a hurricane. So it's not really doing anything. He definitely has a gradient because of the low cardiac index. So this was critical aortic stenosis. His LA pressure was 40, and his left ventricular end diastolic pressure was 45. A V wave of 80. And so, really a very deranged hemodynamics, and we honestly didn't even know whether or not he was survivable. So we thought about what support strategies, and as you suggested, Eddie, that we'd probably try to do something with mechanical support. So just for the audience, you've got 2 basic types of ventricular support. You can do right ventricular support, left ventricular support, or biventricular support. It's very complicated with aortic stenosis because the hemodynamics with AS are really not very well known. So just across the board, if it's pure right ventricular support, then you can use an RP Impella or a tandem device, and both of those provide very good support. And again, the tandem with the right atrial hemodynamics works very, very well. On the other hand, if it's pure left ventricular support, you can use a tandem device or the Impella. We've actually found that tandem has been very useful for severe wide open AI. It seems counterintuitive, but the left side of tandem does seem to decompress the left ventricle and provide forward systemic flow. the Impella can be provided. A balloon pump is just really not of any use in these kinds of patients. And so now this is just without valvular heart disease. With aortic stenosis, it's somewhat different. You can provide Impella if there's biventricular, if there's right ventricular dysfunction. You can also use an RV support. And then we found that for severe aortic regurgitation, either the tandem heart, or I'll tell you about this new concept called left atrial ventricular assist, which is a new method of providing support for the patients that has a lot of appeal, and we've started to use this more and more frequently for these complex valvular heart disease patients. So this is the concept. So veno-arterial ECMO, you have a large cannula that's sitting in the SVC, right atrium, and IVC, and you take blood from the IVC and pull it out, put it through a pump, oxygenate it, and then the oxygenated pump comes back and provides retrograde flow. And that's standard VA ECMO. The big problem with VA ECMO, especially in patients with severe coronary disease, is that you're causing enormous afterload on the left ventricle. If the left ventricle is weak, this afterload causes the ventricle to dramatically balloon out and dilate, and basically causes irreversible injury to the heart. So you can never get the patient off of ECMO if they've been on it for a long period of time with severe coronary disease. On the other hand, this new technique that we have now is inserting a catheter across the intraatrial septum. This is a catheter made by Medtronic, and there's small side holes that are present not only in the left atrium, but also in the right atrium and in the IVC. And so what you're doing is you're actually pulling blood out from both the left atrium and the left ventricle. So blood comes out, and so then this is a combination of arterialized blood and venous blood, goes back in again through the oxygenator and then through the pump to provide arterialized blood flow going forward. And the advantage to this is that the ventricle gets decompressed. And I'll show you this in just a moment, that this is a very unique way of doing it. The other thing is that there's a configuration called ECPella when you do VA ECMO. Because of the worry about the left ventricle not venting, you can put another large bore sheath into the artery and then go retrograde across the valve, and you can pull blood out from the Impella with the Impella catheter. But the problem with the ECPella combination is that you're kind of running out of arteries, because you have to use one large bore artery for the ECMO, one large bore artery for the Impella catheter, and then large bore venous catheter for the venous return. So this is very complicated, but also especially in elderly patients, you end up with a lot of problems with vascular complications with distal limb ischemia. So this combination uses one venous sheath and one arterial sheath. And so you still have access for other devices, and you can support and you can provide retrograde perfusion if you need to. So this really simplifies all of this, and it is a very effective strategy. So this is the technique that we used in this patient. So in order to do the procedure, we have we have an inner-way wire across into the left atrium, and now we're doing a septostomy in order to create an avenue to put the cannula in. You can see on echo that the cannula now is sitting in the left atrium, and again, it's a little difficult to see here, but this is the aortic valve right here, and the cannula is sitting in the left atrium and in the right atrium, and providing flow, basically retrograde from the arterial side. So now these are the hemodynamics in the patient. Look at what happened to the wedge pressure. Wedge pressure is now 16. It was 40. Left atrial pressure, you had a V wave of 80. Now the V wave is 20. So we've entirely decompressed the left ventricle and the left atrium. And so there's no pulmonary congestion. And so the patient is not going to go into pulmonary edema. What happens very often in the patients that you put on VA ECMO is they have a marked increase in LV-EDP, and that translates into whiteout of the lungs. And so the people say, well, thank God he's on ECMO because his lungs are whited out. Well, the lungs get whited out because they have marked elevation of the LA pressures. Here, the LA is decompressed. Right atrium is 8, PA pressure is 30/12, and the PA wedge pressure was 18. So you can see that both the left side and the right side of the patient were decompressed with this approach. So we had the heart team get together. This patient, of course, came in on Friday. And so all of this is done Friday afternoon. And we said, okay, let's watch him over the weekend. If he survives over the weekend, then we'll consider the next step. And thank God he did. He started urinating. His liver enzymes never elevated. He never required to be intubated. So throughout all of this, he actually was awake on this support. So he's got a severe dysfunction of the aortic valve with this homograft, I'm sorry, with this prosthetic valve. And so we decided first to fix the left coronary. And the reason for that is that we were going to have to do a valve-in-valve with coronary protection, and we'll show you that. So we thought that we would stage this so that to protect and fix the complex coronary disease. And again, to really be certain that we had adequate coronary perfusion before we put the valve in. So now this is again, as we demonstrated to you, we did rotational atherectomy into the ostium of the LAD, and then we placed one long drug-eluting stent into the left main. Fortunately, because of the aggressive atherectomy, the ostium of the circumflex really was never impaired. We placed one stent across this large obtuse marginal branch, and then the stent here in the left main. And we got a very, very good result with excellent perfusion. And now he's got good perfusion supplying blood to the entire part of the heart. So that was on day 3 of his admission. And then we let him rest, make sure that his kidneys were still working. And then on day 5, now we're doing the valve. Since we still have one large artery axis available, we were able to do that for a transfemoral approach. We placed a sapien valve, but our analysis showed that we were going to have difficulty with especially the left coronary. We're really concerned about losing the left coronary. So we used the chimney technique to place a catheter in. First, the valve is implanted, and you can see that there's concern about losing the left coronary. And so we did bilateral protection. So we implanted stents in both the ostium of the right coronary and then implanted stent in the left coronary. You can see here afterwards that the flow in the left main and LAD is excellent, and the flow in the right coronary is excellent. I want to acknowledge my friend and colleague now, Dr. Pedro Villablanca, who actually took primary care of the patient, and he's also the one that made all these slides. So I want to thank him in advance for all this amazing work that he did in putting this program together. The payoff is that this is after the valve. There's absolutely no gradient. Pedro then closed both sides. We used Mantif to close the both large bore axis on both vessels, and actually also used Mantif to close the large venous cannula. And we're using that quite a bit now for closing large bore venous sheaths. So all of this was done percutaneously. None of this had any kind of surgical repair required. And then finally, you can see what's happened is that this was the ventricle before, and this is the ventricle afterwards. There's just been a dramatic improvement in LV function really immediately after the valve went in, which shows that we were actually able to protect the myocardium in spite of the fact the patient had massive cardiogenic shock. There was wide open aortic insufficiency beforehand, and there's no aortic insufficiency afterwards, and severe stenosis of the LAD ostium and circumflex, and both of those vessels were fixed. And so these were the findings. You can see that the hemodynamics before and after LAVA-ECMO, cardiac output went from 3 to 7, cardiac index went from 1.2 to 3, the CPO was 0.4, went up to 1.38, left atrial pressure was decompressed, LVEDP was dramatically reduced, the RA pressure went from 20 to 8. Interestingly, he really had very reactive pulmonary hypertension. Once the afterload was reduced, his RV pressure really now responded normally, and his blood pressure was maintained. So I would conclude for you that this is a new approach that you see that these patients really can benefit a great deal from this approach. I'm going to stop sharing my screen for a second, Eddie, and then maybe we can open up a discussion with the group about what you think of this approach, and maybe talk a little bit about these complex bioprosthetic valves and coronary access issues, which are really daunting, and I'm sure you're going to be discussing more and more during the case, during the conference.
Yeah, brilliant case. I compliment you on saving this man's life, and not only his life, his morbidity for years, because obviously you've made his heart really start functioning again. The only question I had is you all decided not to do a valvuloplasty at the same time you did the PCI initially to stabilize him. Was there a reason for that, or you thought that
Yeah,
was
the
too much?
valve, yeah, the bioprosthetic valve was both stenotic and insufficient, and one of the three leaflets, it was hard to see on the pictures, but one of the three leaflets actually was already like just hanging in the
About
breeze.
to fall off.
And if we would have ballooned it, I think the thing would have like completely torn apart. So it would have never survived that. So I think that was what we were kind of, you know, when you have severe AS and AI, valvuloplasty is really tough to do.
Yeah.
And I don't like to do valvuloplasty on bioprosthetic valves. I think they're very brittle. They're like eggshell and they
Yeah.
really tear apart.
Right. The other question I had on the afterload with the LAVA device is you still have arterial return on the arterial side. So that's does that make your AI worse? And I was wondering if that was one of the reasons you may not have done that also.
It doesn't seem to. That's the thing that's sort of counterintuitive. We originally had a patient with infective endocarditis that we put in the tandem device. And so I thought, well, why the hell wouldn't this just, you sort of back circulate?
Right. Yeah.
But you drain the left ventricle so much with both the tandem and this LAVA that there isn't really very much blood flow in the left ventricle, and it seems like most of the circulation is going retrograde. The other thing that I think saved this patient was that he did have a lot of aortic stenosis, and so the blood really couldn't regurgitate backwards. There was some saving to prevent it from going into the left ventricle.
Got it. Yeah, the early core valves were done with tandem heart, and they because of the fear of using ECMO in this type of situation. But I know Tony's been very successful with ECMO in these high risk cases. Tony, you want to mention a little bit of your experience with that? You got to go off mute. You got to unmute. Yes.
Okay, I'm okay. I can recall that the first case I saw with a tandem heart was on Peter's Place in Rotterdam, and that's the real concept. I was going to recall that's the real concept used initially in heart failure patients.
Mm-hmm.
Ventricular assist devices are different, but this standard heart Bill referred to, I think is the most appropriate for the case.
Igor, I haven't introduced my panel yet, but Igor, you have some comments?
Yeah, I think it's very hard to talk about excellent outcome of this case. You can argue with that. Bill, you have to be congratulated. You always have been pushing the envelope, and this is once more Dr. O'Neill's pushing the envelope for this. I think it's an outstanding result. I think that there was one more reason as well to do the angioplasty, the rota stem before, and either you probably will need to pace the ventricle anyhow, and if you have a dilation there, you probably made it hard ischemic at the time that you deploy the valve. So I think that that was very well done, doing the angioplasty rotablator first, and then the valve after that. But I think this is wonderful. So what is the plan for this technique now? Are you planning a national registry or a study, or what is next?
It's like all these new breakthroughs. I think you need a case to stimulate you. We've done 7 cases now of this LAVA-ECMO, and it's primarily in patients that are in shock with severe valvular heart disease. It can be used for aortic stenosis and aortic insufficiency where you can't use an impella. It can be used for severe MR. I don't know whether or not it could be used for VSD, but I think that that's a very good idea, Igor. I think it'd be great to sort of get a registry together, get a work group together for people to start doing this. All of these, the thing that's nice is that all of these tools and devices are FDA approved. Obviously, the Medtronic sheath is approved for other indications, but we can use all of those off the shelf. And so, collecting a registry, I think, is a brilliant idea. And we're just starting talking about it. This is absolutely fresh off the press. This patient just was discharged about a week ago, so this is all kind of very timely for the meeting. But I think it's, I wanted to share it with my close friends because I think you guys kind of need to see, I think, what's a future new treatment for these very complex patients.
I think it's a go. I think it's a go.
It's brilliant. And let's go on, Bill, to your next presentation, and then because I still have to introduce my panel, and then we'll start taking other cases also. So
Great.
can you also show your other left
Yes, I
atrial
will.
adventure?
Can you see my slides, Eddie?
Yes.
All right, so I got to get rid of this other one. Okay. Hold on for just a second. Here we go. Okay, so now I have to switch screens again.
Yeah, displays.
I'm learning. Okay, here we go. So we have a patient that's 60 years old. He's had a mitral repair in 2015. Subsequent to that, he's had 3 CVAs and 2 TIAs. And there appears to be a lucency on his mitral annulus. And nobody knows whether it's a clot, a tissue, or vegetation. He's never had any history of fevers or chills, and there's never been any positive blood culture, so it's unlikely that. And so we wanted to do a vacuum extraction of the tissue so the patient wouldn't need to have another open heart operation, because the only other way of doing this is to go an open heart and then debride the annulus and see exactly what's going on. So we've been using this AngioVac, which again is an approved device for the venous side, and I just want to introduce this to you. Any of these kinds of devices available now, but this is the one that we've most recently had experience with. The AngioVac comes in 2 iterations. One will bend at about 120 degrees, and the newer device actually can bend up to 180 degrees. And this is actually very good for going across the septum, and I'll show you the technique. And then actually you can do this for removing clot from the left atrial appendage. You can remove other clot from the left atrium, and you can advance this antegrade and actually go into the left ventricle if there's been left ventricular thrombus present. The device is a circuit. It hooks up. It's basically veno, and we use it as veno arterial. So we remove some blood from the venous side. It goes into this collection basket and then gets reinserted into the, and we do it in arterial circulation. Some people, if you're only going on the venous, for instance, for pulmonary emboli, we'll just go veno, but in many of these complex valve patients, we're actually doing veno arterial circulation with an oxygenator. So this is again the AngioVac. So the idea is then you go in, it's basically just like a vacuum cleaner. You go in, you grab the particle, and then the flow starts, and you go up to 3.5 liters of flow to really pull clot. And it's really amazing. The device expands, and with enough aspiration, you can actually get long pieces of clot advance, and if they're fresh thrombi, they can be emboli or they can be vegetation. So, our PERT people that are doing pulmonary embolism have looked at this, and we just started using this device recently, and it's actually been very interesting to go in the left arterial approach. The company said, by the way, in terms of disclosure, I have no conflicts. I'm not a consultant or don't have anything to do with the company that makes this device. You can go in from the leg if you have a venous clot, sometimes with subclavian or IV or SVC clots that can be removed from the venous approach from the leg. If you have a right atrial clot or thrombus, you can go in from the IVs from the IJ, and you can even go down into the IVC if necessary. People have used it for removing vegetations from catheters from right ventricular leads, pacemaker leads, and it's also been used for removing massive amounts of endocarditis, primarily from the tricuspid valve. But nobody yet has figured out a way to how to get into the left side of the heart, and that's what I want to show you with this new technique. So these are some of the clots that people have pulled out. And you can see you can just get massive amounts of clot. This is from an ilofemoral clot. This is from a Medport catheter. This is actually Vince Dager is one of my former fellows, and he got this from IC. And then again, you can see that this is a massive clot that's present in the collection chamber. So you can really remove dramatic amounts of clot and debris from the venous circulation. So this is our technique. And so what we're doing here is we're doing a balloon septostomy with a 14 French sheath, okay? I'm sorry, with a 14 French balloon. And then over this balloon, we're gonna track the device. This is the device sitting here. And you'll see in the next picture how we put the stuff together. So this is a 17 French arterial cannula. This is a 26 French Gore dry seal. And through this gorge dry seal, we're advancing this catheter. Now what we've got here is a 14 millimeter balloon, and we put the balloon over the cannula so that you can basically use this for balloon assisted tracking, and this will go right up again into the right atrium. So now you'll watch in just a second, you can see that the cannula then is advanced into the left atrium. And so just watching again, it's sitting in the right atrium. And then as we deflate the balloon, basically we're using balloon assisted tracking, and then the device goes in and sits in the left atrium. This wire is in the left atrial appendage. And this is actually ideally suited if you have a patient that really has a huge clot and you got to get it out. You can get into the left atrial appendage. And we've done this 5 times now. And it's very effective at removing left atrial thrombus, left atrial appendage thrombus. So now this is the device. We've turned it and we've bent it, and this is where the mitral ring is. Obviously, you can't do this without your help from your non-invasive colleagues, and this is almost entirely driven by the guidance that we get from Dr. Didi Wang from our group, who's just been spectacular as a non-invasive imager working with us with 3D guidance. This is a problem that happened. There was a lot of loop in the right ventricular catheter, and after we were done, this loop had gone into the left atrium. And obviously we couldn't leave it. It went across the septostomy, so we had to snare it, and then let me go back on that. We had to snare the device. And you'll see we did a loop snare, and we grabbed it, and now we're bringing the wire back across, because you can't leave this wire in the left atrium. It could be a nidus for thrombus and then another stroke. And so you see we're just pulling the right ventricular lead back in place, and then it pops, and so now it's sitting in an adequate location. This is actually what the tissue looked like, and you can see that it's sitting right here, and this patient had this problem for a long period of time and was referred to us, if we couldn't do anything, he was going to go to surgery to have this removed. This is the 3D imaging. And you can see here is where the device, where the clot is sitting. But this allows us a perfect access of being able to know exactly where we're going to put the cannula. If I can go forward. Let's see. Okay, so now you can see here, and you can see this is the cannula on the 3D image, and you can actually see us coming close to the material that's present, and then activating the device. It was quite interesting. We activated, and the pressure went from like 100 millimeters to 200, and the reason for that is that we're actually coming against this, and you can actually feel something coming into the cannula, and then Didi said it's gone. So we're actually able to really remove the material, and this is the stuff that we took out of the mitral annulus, and you can see that there's large hunks of tissue, and we sent this off for histology. We actually just did this case 2 days ago, so again, this is really kind of fresh off the press. We don't have the surgical pathology yet, and we don't have the cultures, but this is basically save this patient an operation. This is what it looked like before. And now you can see that basically all of that free tissue has been removed. And you can see now that this is what it looked like before. And now the entire mitral annulus has been entirely cleaned out. So I think this kind of shows you where we are with these current therapies. I think that this is a new approach. It's got a lot of potential for removing. We've been working on the left atrium, doing left atrial appendage occlusions, and we're very often faced with patients that have large clots in the left atrial appendage. So this is a perfect way of being able to remove it. But it kind of shows you, we've also removed a left ventricular myxoma. This is a patient that was having recurrent strokes, and we were able to put the catheter across the left ventricle and then remove it that way. So it's a new technique, which I think your group might find interesting, Eddie, and I think that there may be a great deal of application from others that are doing these kinds of procedures. So thanks very much, and it's an honor and a privilege to join you.
It's brilliant. Again, another unbelievable thinking out of the box. We've had some success with the AngioVac in the right side. We have not tried anything on the left. Of course, the big problem is we didn't really have that cannula also with the that allows you to make that flex, which was so important. That was really missing. Remember, you had to use the suture on the device to pull it and so forth. But this is brilliant, and of course, I'm sure you're also protecting. You're using a sentinel device, or you're using
yeah, absolutely,
your inverted Watchman device technique for protecting the brain.
Yeah, we're not using the Watchman anymore because they're not going to manufacture the classic device, and the new Watchman Flex, really you can't use it for a fill for like an umbrella. But so we decided just to go with cerebral protection with a sentinel.
Wonderful. I'm going to go ahead and introduce my panel, and then we'll take some more questions from the panel if they have it, or if not, we'll go on to the next few cases. So you've heard some of them already. One of them is Igor Palacios. Igor Palacios is a legend in interventional structural heart disease, and he's taught many wonderful structuralists throughout the nation. Here in South Florida, we have quite a few. He's a professor of medicine. For decades, he was the head of the cath lab at Mass General Hospital. He's a professor of medicine at Harvard now, and he's going to be joining us later with some cases also. The next person is Antonio Dager. Antonio is the chief medical officer on Geografía de Occidente in Cali, Colombia, one of the very early people to do a transcatheter aortic valve replacement in South America, and has now become like a Johnny Appleseed of TAVR all over America. He's trained many interventionalists and structuralists throughout, and so he'll be showing us some cases and commenting later. Mauricio Cohen, I don't know if he's had a chance to join me yet, but he will be joining me shortly if not. He's the director of the cath lab at the University of Miami Hospital and a professor of medicine. Carlos Alfonso, a dear colleague also, an expert in structural heart disease. He's an associate professor at UM and a cardiology fellowship program director, as well as the director of advanced coronary and CTO interventions at the University of Miami Hospital. The Giselle Baquero, who is an interventional structural cardiologist at the University of Miami, at the University of Hawaii Heart Associates at Ventus Castle in Honolulu, Hawaii. I envy her every day. She's a former structural fellow and a brilliant thinker also outside of the box. Camilo Gomez, our structural heart disease graduate last year, is now interventional cardiologist and structural at the University of Miami-Jackson Memorial Hospital. He's an associate medical director for interventional cardiology there. Sergio Perez is my current structural heart disease fellow, the third or second Everhard Grube International Structural Heart Disease Fellow, and will be soon graduating in June. And he's going to be helping a lot of people in Alabama when he's finished with us. And then Hector Rivera, I hope, has already joined us. Hector is an interventional cardiology fellow and will soon hopefully be also a future structural fellow. He's going to be helping us compile questions and so forth from the audience and bringing it forward. So first of all, any comments from my panel? Remember, you have to open your mics if you're going to say anything.
Yeah, I have one question for Bill. Bill, I learned that you're doing some special stuff with calcific mitral valve. And I was wondering if you are using this AngioVac technique to try to withdraw calcium that you may have break with your device.
I think the calcium is really too stuck to the heart. And, you know, the surgeons really are petrified about doing that, because if you can remove some of the annular calcium, the heart tears and falls apart. So I think this device is more suited for, you know, softer material like clot, or like you could, for instance, use this very easily when you have a endocarditis on a mitral valve, where you're worried about that embolizing. And so I think that's another, you know, effective technique. The kind of breakthrough we've made is that all of this was done on the venous side. And now I think you can really now start going across the septum and doing left-sided interventions with this.
Yeah, I was wondering if you using the catheter to break the calcium. I mean,
No.
the possibility that some of the calcium may become loose. And
No,
if you had the
what we've
device, you
done
would
is
be able to grab it.
we're using the shockwave balloon. We're taking 3 7mm shockwave balloons and inflating it in the mitral annulus to do shockwave of the calcium. And that seems to cause microfractures, which allows the calcium to spread. And in patients that have severe near circumferential mitral calcium, balloon valvuloplasty actually is pretty effective at fracturing and opening up the orifice. It just doesn't last for a long time. So we're working with shockwave to make a larger balloon, and I think that will be a very good technique. The shockwave is actually going to be an interesting technique to use for aortic valvuloplasty, but they just need to get a bigger balloon, and I think they're working on that right now.
Bill,
Yeah.
Bill, this is
I mean,
Tony.
with the calcific mitral, I mean, sometimes we get very spectacular immediate results, but they behave like an aortic calcific valve. In 6 months, they're back to what they were before. So,
Right.
But I was very intrigued about this shockwave technique. I learned from Christian Whiskey. He's in his regard, and he was very excited about learning about this technique.
Yeah.
Eddie, perhaps I can ask Bill. Every 4 LVADs produce some kind, or at least severe, AI.
Mm-hmm.
Many patients.
Yeah.
Now that you proved this concept of atrial venous assist devices, perhaps it can be changed. Perhaps this is a venue for new devices that won't produce AI in many patients.
Yeah, I think that, you know, it's an open avenue. I think I'd invite everybody that's interested in doing it. We have to kind of start using it and share results. I don't know who the ideal patient for this is, and it's still, you know, lots of different techniques. You have to have comfort with doing transeptal punctures.
Yes.
Igor could do them in his sleep right now, but have difficulties. So you have to know, you have to be comfortable with that, and you have to have a good perfusion system available. Eddie, I've got a comment.
So I unfortunately have to go on to other cases, and because if not, we won't get through this evening. So let's go on to Camilo Gomez. He's going to show us a very interesting case. So Camilo.
Okay.
If the other panelists could mute their system.
They're displaying? Okay. Okay, good afternoon. Happy to be here. Thank you, Dr. O'Neill, for always delighting us in Miami Valves with your amazing lectures and cases. So I'm going to present a case that we did a little bit ago. So this is a 78-year-old Hispanic man. He presented initially 2 years prior with severe AI. He underwent a surgical valve replacement at an outside institution with a Percival XL self-expanding valve. The procedure was complicated with a complete heart block. He required a permanent pacemaker and Around a year, 1.5 years after the surgery, he had a recurrent of a exertional dyspnea and worsening of functional capacity, and he presented with a recurrent heart failure symptoms besides medical therapy. This is the Percival valve. It's a suturous valve. It's one of the rapid deployment valves. It's a bovine pericardial valve mounted on a self-expanding nitinol frame. The valve is crimped and collapsed and mounted in a delivery system. The procedure is performed on minimally invasive surgery through an anterior thoracotomy. First, the native valves are removed and excised, and the annulus is decalcified. Then the valve is implanted with novel fixation techniques. The use of minimal sutures around the annulus that to provide with the purpose to increase the effective orifice area. And after the valve is deployed and released, there's a inflated with a balloon for better expansion and optimal sealing of the annulus. The valve design and the engineering is kind of a little bit of complex. It's made of 2 rings, one outflow ring and an inflow ring, and the rings are interconnected by a complex system of waves. These wave shapes connectors that give support to the valve and help anchoring to the sinus of a Valsalva. And this is important for a case that I'm going to show you. So patient workup had transthoracic echocardiogram. We see a significant jet of aortic insufficiency that seems to be coming in outside frame of the valve, suggestive of a paravalvular leak. Further workup with a transesophageal echo showed that the jet of the aortic insufficiency and was a consequence of the paravalvular leak, and was located in the towards the right sinus of Valsalva, very close to the right coronary artery. Then here you see this is from the aortic view. This looks larger, and this is flipped, so it's in very anterior position, and is a considerable size of a PVL. So our initial approach, we wanted to close it percutaneously. We attempted retrograde approach. We tried multiple catheters to cross the defect, multiple wires, glide wires, glide catheters, etc. And we were not possible. We didn't have any success crossing the defect. We have a significant interaction with the band frames, with the rings, and especially with the connectors of the valve, and was very difficult to manipulate the catheters. Also, the larger side of the defect was in the ventricular side. So at this moment, we decided to stop and reconsider the case. So this is a question to the panel: what will you do next, and how you will approach this case? You will consider continuing medical therapy. Besides patient having recurrent symptoms, you will try to integrate approach, reduce surgery, try to have balloon dilation, or any other approach that we're open to for suggestions.
Yeah, I would like to see a CT scan.
Okay. So we did a CT scan and we got some measurements. The paravalvular leak was very complex to image. The location, it seems that it was larger in the ventricular side. Also, we get some measurements of the valve. We know that it's an axial valve. It's the largest of the 4 sizes of the Percival. They had a very good coronary height. The RCA was at 23 millimeters, the left at 38, and an excellent VTC. Both sides at the right and the left were more than 10 millimeters. A wiry white sinus, more than 38, 40, and 40, and a very favorable angle of 46. This is I want to show the valve. The way it's designed is and the material nitinol. It is designed to be acquire the annulus shape. and move with the annulus and the heartbeat. So that's why it's very difficult sometimes to get the good images and sizing, but and a very favorable vasculature. So based on this, what would you consider? This is our XL valve. We know this is used for a 25 to 27 millimeters annulus, and this will correlate either for if you're planning for a valve at 29 millimeters 3 or a 29 Medtronic valve.
Yeah, so here we were, I mean, obviously we thought that we would see if we could balloon the valve and see if it would regain its shape and retain its shape, to see if we could stop the leak with that instead of going antegrade with the perivalvular leak. But we thought that it may not, and we were pretty sure that putting another nitinol valve in there wasn't going to help any. So we were thinking about putting the more rigid S3 valve with more radial strength to try to shape it. I wonder if anybody else has any thoughts on that. Bill?
Eddie, it seems surprising, since the surgeons removed the valve, the calcified area, that you wouldn't get a complete circular expansion. But I would agree with you. But it's really problematic to go antegrade. You could potentially go transapical, and we've done some of these complex cases. That's actually very straightforward to do, because you only need a 6 French sheath to deploy some of these plugs. But it would be very problematic to actually find the hole and open it. And I think that it looks like the leak is right exactly where the valve is not circularly expanded. So I would agree with you that trying to do something, a valve and valve with an Edwards valve, I think would be a very good approach.
Okay, so Dr. Marchena said, so we plan for a second procedure. This is a baseline aortogram. We can see the jet of the leak. Initially, from previous experience at the University of Miami with the previous self-expanding surgical valve, in that case, another was an intuitive valve. It worked with the balloon expansion. So that was our initial approach. Do over like general anesthesia, PE guided, and try first to do a balloon expansion. In this case, we use a 26 millimeter balloon. You can see the first expansion, there was a small waist toward the left in the balloon. So we added 1 cc more, and we have a better and complete expansion with a better expansion of the frame. But we wait around 5 to 10 minutes, and we saw that there was some improvement, but there was persistent of the leak. So we plan ahead, and we'll have us a Baylor strategy as backup to implant a percutaneous valve. So we decided to proceed with a valve-in-valve TAVR. We have a little bit of discussion with our heart TV, which we use self-expanded or balloon expandable. As Dr. Marchena mentioned, we wanted to have a better radial strength, and also be sure that we're not going to have any recall putting another nitinol platform. So this is the crossing of the valve. Was very easy. Unfortunately, the was a very favorable angle. This is the position of the valve. We wanted to position our valve marker in the lower ring, just above the edge of the stem frame, and because to have the best radial force and strength at the level of the leak. This is our deployment under rapid basic conditions, slow deployment. And this is the final aortogram with the resolution of the leak. On imaging, this is pre and post. We have a complete resolution of the paravalvular leak. And see there's no residual yet of AI. and follow-up patient have a complete resolution of symptoms. So that's the way that how we approach this challenging case.
Comments from the panel?
What was the failure mechanism, Eddie? Why did the original surgical valve fail? It seems odd that they weren't able to get full expansion. And was there an echo done post-op, like either in the recovery room or something, to suggest that there was a lot of AI afterwards?
You know, when you talk to the company says that it's usually under expansion, but they actually had an intraoperative TEE that showed no AI. And so, but shortly afterwards, like in 2 or 3 days, the guy started developing AI, and then he developed frank symptoms from aortic insufficiency over the next few months. So I don't know the mechanism. I agree with you that calcium should have been gone. I'm wondering whether it's possible to have a little infolding of the valve, like we see with the core valve sometimes, and that maybe even with visual inspection you can't tell. But it really looks like if it's buckled right at the spot where we had to pop it out. That's why I was hoping that we could pop it. Even though it was nitinol, we were hoping we could pop it back in place, but it didn't do it. It was interesting because it would look like if we had resolved the leak. And then after, like, as Camilo pointed out, after a few minutes, it was back, so it was jumping back.
I got to tell you, trying to fix these TAVR PV leaks with plugs is just kind of it's an exercise in futility. We had a bunch of those in the early days of TAVR. 20 or 30% of these patients had severe AI. And we would try to go in and put holes in antegrade and retrograde and all of that. And you never really ended up with a very good result. It seemed like the most consistent result was to just put a valve in valve. And that seemed to give you more durable, results. And I think that still is kind of my go-to right now to try to fix these PV leaks.
Wonderful. I think we're going to go on to the next case. The next case, Igor is going to show us some complex ASD cases. So Igor, can you go unmute or mute, whatever, unmute and show us your screen share.
Well, thank you, Eric, for the invitation to talk today and to share this with my good friend Bill O'Neill. We're going to talk about the closure of complex atrial septal defect. And I have to do that by illustrating you 2 short cases. The first case is a 60-year-old male with a history of hypertension. He was born with a Noonan syndrome. He had a surgical repair of pulmonary valve stenosis in 1987. And then he actually come back and was admitted to the MGH in 2006 for a percutaneous closure of an atrial septal defect. An echocardiogram in 2006 showed normal EF, right atrial dilatation, pulmonary stenosis with a peak grading of 28 and a mean grading of 15. And he had moderate pulmonary regurgitation. The right ventricular systolic function will, however, preserve and have an estimated pressure of 59 millimeters of mercury systolic. The patient was found to have an atrial septal defect with a right ventricular volume overload, and the patient essentially was having some fatigue. Due to early right ventricular failure, it was elected to proceed with percutaneous closure of his ASD. Cardiac cath at the local hospital initially was made aiming for an ASD closure, but when they found that the PA pressure was elevated, they aborted the procedure, and then the patient essentially was referred to Marchena. His coronary arteriogram, however, shows he has minimal obstructive, non-significant disease of the LAD and the circumflex. His past medical history, he has a history of arterial hypertension. He had this Noonan syndrome. He's started for surgical valvuloplasty for pulmonary stenosis. He have a history of ASD with fatigue and right atrial enlargement, right ventricular volume overload by TTE. And he have a history of overweight with sleep apnea that resolved after he lost 60 pounds. The physical exam essentially show a systolic treat at the upper left sternal border and a 4/6 systolic ejection movement. The rest of the physical examination was unremarkable. Here is his electrocardiogram. It showed essentially normal sinus rhythm, right axis deviation, and right ventricular conduction defect, and non-specific ST and T-wave abnormalities. Nunes syndrome is a genetic disorder that causes abnormal development of multiple parts of the body. Typical, these patients have a distinctive facial appearance. They have short stature and a broad or web-back neck, congenital heart defects, bleeding problems, problem with bone structure, skeletal malformation, and development delay. Atrial septal defect is one of the more common type of congenital heart defect, and it accounts for 6 to 10% of all the cardiac anomalies that occurs in 1 in every 1,500 births. Here is the echocardiogram of this patient showing a large ASD, as you can see here. And then in the next one, you can see here in the color, you will see the ASD very well seen here on the, you could already appreciate that there appears to be 2 jets, probably 2 ASD or fenestrated fossa. Here are his hemodynamics. His right atrial pressure was 7, the left atrial pressure was 11, and there was a 10% increase in the oxygen saturation between the SVC and the PA, giving a left to right shunt over 1.5 to 1. By echo intra-procedure, he was identified different parts of the procedure to end up having 3 separate atrial septal defects. The first one located superior and anterior, measured 24 millimeters. The second one located medially and small in size, and the third one located inferior posterior and size to 12 millimeters. You could see here the 2 ASDs, and you could see here the measurements for the, just using the color for the 2 ASDs seen on the fossa. You could see here more measurements, 1.7 and 1 centimeters in diameter. So you also assess the rims, the anterior rim, the posterior rim, superior and inferior rims, and they appear to be okay in this particular case. To measure the size of the defect, we use what is called the stop flow technique. And essentially, the stop flow technique just uses balloon sizing for the atrial septum, is inflated until you eliminate the left to right shunt by echo. When you get there, then you start to deflate the balloon until the left to right shunt reappear, and that is the stop flow diameter of the ASD. Then you use that as the sizing of the ASD, and you add anything between 2 and 4 millimeters to that measurement to choose the device that you're going to use using the ASD unplugged device or the nowadays the cardiophone device. You could see here how this technique of ASD sizing is used. You see there the flow going through the ASD, and in the next slide you're going to see the balloon. You could see here straddling the atrial septal defect, and essentially you will deflate the balloon a little bit until you get flow back for the left to right shunt. And that will be, again, the stop flow sizing of the ASD. You could see here the measurement. And essentially the next thing that happened here was that a device was used to close the 2 ASDs on the fossa that will cover both of them. And then after that, we identified that the patient have a posterior inferior ASD that was small. And then essentially at that point, this device has to be removed because you want to deploy the small device first so you could sandwich it with the big device. So that you will see that on the next slide. You see the deployment of the small device, posterior inferior, and the other guide wire into the pulmonary vein to save the access to the ASD. After the removal of the device, then you could appreciate the extra ASD, the third ASD. So there were 3 ASD to close, and the first one that was closed was the first device. So the first one was removed, the small one was placed to close the third ASD, and then after that, and you sizing the 2 holes in this case, you come back with the balloons and you size the larger ASD, and then you use a larger ASD device to cover both of the holes in the fossa and sandwich the small device in the third hole shown here in this slide. You could see here the small device closure, and you could see it here with the echo as well. Then the next one, we're going to see the larger device now straddling the septum and sandwiching the small device in the bottom, as you can see here. So essentially, you use a larger device to cover the 2 holes in the fossa and a small device to cover the posterior inferior defect on the atrial septum. And by doing this sandwich, you end up occluding the 3 ASDs. You could see here very nicely the on angiography, the small device, the larger device overriding the small device, sandwiching that. And you could see here the 2 devices in place before you release. And next you will see the final angiogram, the final photo showing the 2 devices holding these. And that actually have no residual shown through these 3 ASDs. These are now follow-up, 1-year follow-up, essentially. This one, I think that is not playing, but it's okay. Essentially, you could see here the device in the atrial septum here and here. And this was an attempt to do a bubble study, but nothing got through the ASD by injecting into the right side. And there was no left to right shown by color flow. The patient has done well. This is his last echo from July of last year. You could see here the device in the atrial septum. This is the first injection of bubbles into the right side, and you actually see nothing going across into the left ventricle. And the same down here and here, showing essentially that this patient is doing quite well and the hole well closed. So this actually illustrates how you can do that. Now I wanted to share this other case that was actually done by my good associate, Dr. Ignacio Ingleses. This is he participated on the ASSURE trial that assessed the use of the cardioform atrial septal defect in patients that have complex ASD, large holes, or patients that have insufficient rings. And quickly, this ASSURE trial was already completed. 125 ASD patients were enrolled in this study. And the technical success was 96%, although they had to remove 3 devices in the first 24 hours. The scheduled follow-up was 6 months, 112 returned for evaluation, and all of them were closed successfully. There were some adverse events in 4.8 of the patients, including new arrhythmias and some wireframe fractures occurred up to 36%, but they had no consequence. There was no residual shunts. So this patient is a 52-year-old woman with progressive shortness of breath, a TTE revealed a large ASD with right ventricular dilatation, and a cardiac catheterization show a right atrial pressure of 6, PA pressure of 24/7, left atrial pressure of 7, and a QPQS of 1.6 to 1. You could see here the size of the ASD. It's a very large ASD. It was sized, as we can see here, to 16 millimeters in the short axis and 38 millimeters in the long axis, suggesting that this ASD was not round, but was more rather elliptical. Here you have it again, the measurement for 24 and 52 millimeters. And here are 3D images of the sizing with the stop flow technique. You can see the balloon essentially here, occluding the ASD, and then here as well. Then the question is, what you are going to use to close this? The balloon stretch of 18 by 28 or the 3D TE maximum of 26. And how do you choose the device size? The larger balloon stretch diameter, the average maximum and minimal diameter, or the larger diameter by 3D TE. There are recommendations that have been put in after the use of the ASD occluder by this sizing card. And essentially for the size of the ASD, we probably are going to be using a 44 millimeter gold cardioform that will cover a range between 23 and 30 millimeters diameter size. Here you could see now the deployment of the dead size of the device. Here on the echo and here on fluoro. And in the next, you're going to see the deployment of the right side of the device, here on fluoro and here on the TEE, essentially showing a very nice deployment of the device and no residual shock. One of the problems in doing this patient with TEE was that Ignacio referred that they couldn't very well visualize the posterior rim and the inferior rim with the TEE. And then they use something very smart. They use the eyes in combination to evaluate the posterior rim, so as an adjunctive technique. And you could see here essentially the device deployed with no residual shunt. And here is the imaging from eyes looking the inferior, posterior, and the superior rim, showing that they were sufficient when the device was placed. There are some advantages or disadvantages of the use of echo versus eye, but you could look more of them as techniques that will not exclude each other and will be helpful to make a better assessment of the rims and the device deployment. Here is what the device looked like when the procedure was completed. So in conclusion, transcatheter closure is feasible in anatomically complex substrates of secundum ASD. It's necessary to have a careful case selection, a scrupulous imaging protocol, and expertise in modified technique are mandatory for successful outcome on this patient. Thank you.
Beautiful, beautiful cases, Igor. We've actually been, we've had to use also ICE in combination with TEE in cases where we're not sure about the rim. And it is incredible that you can see the rim usually significantly better with ICE than you can see it with TEE, even though you're a little more lost in the orientation, but the actual perception of the rims are significantly better seen. Any comments from Bill or?
Igor, I have a question. In that second patient, obviously there was a massive ASD, but the hemodynamics actually really didn't look that bad. The PA pressure and the RV pressures were actually, and the LA pressure actually were quite low. So can you comment, what is the mechanism to cause the exertional dyspnea without really having any kind of left atrial pressure?
Yeah, I don't know, Bill, but often we see patients who say that mainly you have shunts, and they don't have very high pressure. They equalize because they have a big hole, and but they don't have the left atrial hypertension to produce dyspnea. But they often complain of fatigue and dyspnea. Those are very typical symptoms of these largest ASDs.
Yeah.
It's very important, of course, to measure these shunts. And, you know, with the cath lab now turning more into an angiographic place and an interventional place, we found that often our fellows get very little training on assessing hemodynamics and ask this kind of question that you're asking now. And to see, you know, calculation. Sometimes when you have bidirectional shunt and you have to calculate right to left and left to right, they get very confused. And I think that it's hard for fellows nowadays to get trained optimally like we did way past when we have more play with the hemodynamics and the outputs and the saturation of these patients. But I think that's something to look for the future. What we have done now is that essentially the structural fellows are the ones that are more involved with these because they got to think about, you know, these shunt calculations and do it better. But that's a good question, Bill, and I don't know. I don't know if people have done the cardiopulmonary stress test. It would be fascinating to see what happened to this patient when they got dyspnea.
Yeah.
So Giselle, you want to comment a little bit on your experience with ICE in left atrial appendage closure? Because I think that we're probably going to be going to something like this very soon.
Yes, sure. Well, first of all, I wanted to thank you for putting this together and being able to see all these wonderful faces again. It's such a privilege being in the panelists, and also thank Bill and Igor and Camilo for those amazing cases. Professor O'Neill never ceased to fascinate us with his cases and his forward thinking and out of box thinking. And I have a couple of questions for him, but I'm just gonna comment on the ICE feature briefly. So yes, I think that's the future. I think that we should be able to simplify these procedures, and they can even be able to be done on patients being completely awake if they're not as anxious as they're being done in Europe. They're straightforward. There is a learning curve to them of probably about 5 cases was in my case, but nowadays, you can even do it with the newer generation of ICE devices. You don't even necessarily need to cross to the left side as we were doing. You can probably even like Philips, and I'm not able to disclose more, but the new imaging that is coming up is so pristine, and it's going to be probably like having a TEE inside of the right atrium. So you can probably just stay down there and do the whole procedure from there and come out. So we're talking about like a 30-minute procedure or so, very safely done in the near future. But nowadays, you can do these procedures with ICE. You cross to the left side. But what I like to do is I don't do 2 different septal punctures as some operators are doing. I do a single septal puncture, dilate with the Watchman sheath, bring the Watchman sheath back, and then just override the catheter into the left atrium. I park it in the left pulmonary artery just to take some preliminary pictures, but then afterwards you can just do the rest of the procedure and assessment from the left atrium with the ICE catheter. But I guess the key to this is just making sure that all of these cases have a CT prior. So you really need to know the anatomy, and I will strongly encourage for all of these cases to be CT assessed and people to actually be familiarized with reviewing these the anatomy on CT and not just sending to the vendors and having them back. Or if you have somebody as amazing as Bill does with DD1, non-invasive support, then that's the ideal case for it. So that's
very good. So we've tried it a few times now. I still haven't been as courageous as you to try it without. We've tried it in conjunction with the TEE. I know you've had a couple of cases that couldn't have a TEE because of anatomical reasons, and I think that that's really the ones that I probably should do cleanly. We have been doing that same puncture and dilatation technique, single puncture. I think that that is probably the best way to do it because double puncture is just cumbersome. But I mean, I think that probably pretty soon we'll be able to use this tool for Watchman's and maybe for some of the things that Bill is showing us. And then we may not need to put these patients under general anesthesia, which would make things a lot better for the patient. So unfortunately, we have to go on to the next case. And then we'll maybe later on we'll go into more questions, but we still have several excellent cases to look at. So Sergio, you're going to show a case now?
Sure. Good evening, everyone. I wanted to thank Dr. O'Neill, the whole panel, and the attendees for signing in. I hope you're enjoying. This is a short case. This is an 84-year-old gentleman who comes with heart failure, New York Heart Association, class 3 symptoms. He has medical history of myasthenia gravis, AFib, and an abdominal aortic aneurysm. And for those comorbidities and his age and some frailty, he was turned down for surgery. He had a diagnosis of severe symptomatic aortic stenosis. And you can see his EKG has some degree of baseline conduction normality with that right bundle on AFib. His echocardiogram showing preserved LV systolic function, calcified stenotic aortic valve, and high gradients and velocities confirming the presence of severe ES with a valve area of 0.7. This is a picture of his right coronary. It seems there is some narrowing here, but it turned out to be some epicardial vasospasm. We repeated the picture after a few minutes, and you see that the narrowing improved. The left had also some luminal irregularities, but no significant obstructive disease. So we continue with the work after transcatheter aortic valve. These are some measurements on the CT, and what I wanted to highlight is when we measure the annulus, we obtain an annulus area of 740 with a mean diameter of around 30. So for all the attendees, the available valve that we have commercially, like the valve that we have commercially available, they cover a range of annulas. But for one of the platforms, the maximum area, it's around 683. For the other platform that it's mainly based on perimeter, it's around 92. So this patient has a large annulus, which is above the manufacturer recommendation. And I guess this posed a question: when you have an annulus that is larger than your available transcatheter valve, what would you do? What would you choose? Just to give some more analysis from the CT scan, you have a normal take of the coronaries, but you can see a borderline angle of the aortic root measured at around 66 degrees. And you see the pattern of calcium in the annulus and some subannular calcification. So moving forward in terms of access, he had favorable transfemoral access, on both sides. So I get this question, I mean, the question at this point is how most people treat large annulus. Do you choose one type of valve over the other? And if you choose a balloon expandable valve, do you go nominal? Do you overexpand your valve? And I guess it's just a quick question for the panel.
What would you do here on this size annulus? So Mauricio joined us. Mauricio, your thoughts here?
Can you hear me there? Sergio, can you show the measuring again?
Yeah.
So the thing is whether you choose a self-expanding valve or it's complicated. I mean, you have enough calcium there to engage. So how much undersizing do you have with a 34 evolute? I mean,
so based on CT, a 34 evolute would be between around 7% undersized.
Undersized, and then with an Edwards.
And with the 29 millimeter Edwards at nominal would be around 10% undersized.
But then you can add additional, well, but then you can not. So I don't know. I think that I would probably go with with a balloon expandable, because the only reason is that if you have too much circumferential leak, you can put another valve inside and expand and then oppose the skirt of the valve to and make it seal around the annulus. The self-expanding valve, I mean, even though you can place it high, so you have the maximum diameter at the lower end of the skirt. The problem is that these valves sometimes tend to dive a little bit, and then you can end up in a situation where, you know, the valves move deep, and then the valve is too deep, and then impinges on the valve and impinges on the mitral valve, and then that becomes kind of a disaster. So I think you would probably have a more controlled deployment with a balloon expandable valve, and possibly thinking about doing a valve-in-valve if you have circumferential leak.
Bill, any comments here? What would you do?
Yeah, I would agree with Mauricio. I think that there's plenty of calcium on the leaflets to hold the valve, so I'm not really worried about the valve embolizing or migrating. It's really basically a matter of paravalvular leak. And there's a series that's shown that they've implanted the 29 Edwards in valves as large as 840 in area. So this one actually doesn't really worry me too much. I would put in a 29 valve with 6 extra cc's in the syringe, and then slowly inflate until you're really getting a good result. If you put in too much, you'll get central leak, and you can always just put another valve inside that one. So that would be our approach. We've done kind of almost 2,500 TAVRs here at Henry Ford, and I can recall 3 where the annulus was too large. So it's actually not that common.
Yeah. Sergio, go ahead and show us what you did.
Sure, absolutely. So moving forward, we decided, because of the angle and all the reasons that you mentioned, we decided to go with the balloon expandable valve. And as Dr. O'Neill just mentioned, this is the first feasibility study of overexpanding a balloon expandable valve back in 2015. Just to mention for the audience, the 23, 26, and 29 Sapien valve, the balloon is inflated with 17 cc's. For the 29 millimeter, the nominal size for the balloon is around 33 millimeters. So in this study, they noticed that when you add 4 cc's to the balloon, you actually get an area of 740 with a mean diameter of around 31 millimeters, which is exactly the measurement for this patient. So we felt like adding 4 cc's to the balloon would size precisely this patient annulus. And just quickly to mention, this has to be trade-off with some of the risk of overexpanding the transcatheter valve. You can see on the top, this is a 23, a 26, and a 29 millimeter. All of them overexpanded with 3 cc's. And you can see how this, especially the smaller valve has a coaptation gap with closure and restriction. So just a little bit of trade-off. This translates into a higher regurgitant fraction of smaller valve. It doesn't see it, not very noticeable with the larger 29 millimeter valve. So with this patient, we decided we're in the day of the procedure. This is our baseline angiogram and the high gradients of severe ES. We pre-dilated with a 25 millimeter Edwards balloon. And you can see the maximum inflation of the balloon. And then we went ahead and advanced the delivery system of that balloon expandable valve. We crossed the arch, we positioned our valve in the native annuli. And this is the deployment with 4 cc's on the balloon. And a couple of things to mention is notice the foreshortening of the valve. So we aim a little lower because this valve, when are overexpanded, they tend to foreshorten from the ventricular side. So we're pushing on our delivery catheter and at the moment of our deployment. And once deployed, you can actually see the degree of foreshortening. Based on that first feasibility study that we showed, the expected foreshortening when you add 4 cc's to 29 millimeters, it's around 8.5 millimeter. And that's what we saw in this case, a foreshortening of around 7.2 millimeters. So this is the final result. I don't know, we're shallow, we're 95.5.
Beautiful. So some really wonderful teaching points in that case. And then a person who's mastered the large annulus is Tony Dager, and he's going to be going next with another challenging large annulus case. So Tony?
Greetings to the new arrivals, Dr. Cohen and Dr. Alfonso. Good afternoon to you. Bill, it's a pleasure always to be with you. This is a 59-year-old gentleman. Let me see if we can start with this. Okay. With the case, this is a 59-year-old gentleman that, let's look at the, hold a second, this is the end of the case.
Yes, you had to start at the beginning.
Come on. Okay,
Spoiler alert.
there we have it. I think so. Okay. This is about an extremely large annuli and bicuspid AS with severe systolic dysfunction. Okay, this is a 59-year-old male that works in the entertainment business in Cali. And one of those bars, they dance salsa. I think some of you have frequented. He had heart failure, diabetes, dyslipidemia, and severe COPD. 6 months of increasing dyspnea. And the outpatient evaluation showed, the TE showed left ventricular ejection fraction of 16 with severe aortic stenosis. He meant severe by grading only 25, and also with severe calcifications that we can see. We discussed the patient with the heart team, and they dismissed surgical option, given the severe comorbidities and especially COPD and the heart failure, and because of severe calcification. I don't know, that's what they answered. Obviously, with a poor ventricular function. He had STS with 13. Let's see the images quickly. Okay, we can move in this into the, okay. So you can see his ventricular function there. And the large, very large chunk of calcium in the aortic region, and the aortic valve. Okay, you can see it in the short axis. His coronaries were essentially normal. Is on. So you can see his ventricular function by angiography was very poor, accompanied by some kind of AS, AMR. And now he doesn't go with the AS. He doesn't have AR. Go ahead, please. Those are his peripherals by angiography, again. And here's the CT measurements. When we measure CT, okay, his perimeter was 112.7 millimeters. The annular area was 1,028. His mean diameter was 30.6, the smaller diameter, and 40, the largest diameter in that case. And right here we see the chart. We observe the chart of the range that the valves, one platform or the other can reach. And none of them reach that. None of them reach that kind of area and that kind of perimeter. So we look more at the CT scan. And we could observe that it was a heavily calcified bicuspid with a calcified annulus. By the way, this is the type of bicuspid that has the worst prognosis, not only per se, also because it carries the problem that it increases from 1 to 5% the ventricular the annulus rupture, especially when you use large, very large balloons. They're only in the self-expanding, also in the balloon expandable platform. Next, this is the way to remind you, this is the valve sizing. We go up from the level of the annulus, then 4 millimeters above where we do a neo annulus, and perhaps 10 millimeters above, almost in the sinus region, and we do the intracommissural range, okay? So that's what we perform there. I hope you're looking and you're observing well. This is the basal region where we obtained the measurements you had, 1,125 millimeters of area, a perimeter of 115. When we go up, we measure a new annulus, and we observe almost 600 millimeters of perimeter. Excuse me, an area of 500 millimeters and a perimeter of 894 millimeters. Okay. Then what would you do with this case? The discussion. It's just only two decisions. Would you go for a surgical treatment of this 59-year-old gentleman with that type of ventricular dysfunction? Or would you go with TAVR with some kind of ventricular assistance device? I can listen to you. Okay.
Tony, what was the ejection fraction again? I'm sorry.
It was only 15%, Eddie.
15%. I misunderstood.
1.5.
So,
Right.
Bill, what do you think?
Tony's teaching us. I don't know if I would have tried this one with a perimeter area of 1100. I'm see that's way too large. But he did what the com to com distance on the bicuspid valve was 34. So it's possible that a 34 core valve might work. But honestly, I don't think I would have the guts to try it. So Tony, I'm dying to see what the results are.
Sometimes around your life, you're not able to prove what you think about, and this is a proof of concept.
Yeah.
That bicuspids, you can implant them above the annulus, and enjoy the calcium you have above, the region, the habitat, and perhaps the reason, mainly because I'm accustomed to use core valves, I didn't use an S3. I would have to use how many centimeters, Sergio? Could you remind me how many? About 20 more to be able to reach that imaging. But that's a concept and very well.
Yeah, Piazza's been telling us for a while that we're not measuring bicuspids correctly. But I think it's that the thing is that there's a whole spectrum of bicuspids, and this is a Siebert 0 or whatever that. This is a true super bicuspid valve.
By the way,
these are different, you know.
The article published last year, but soon, and the Bavard people, they show that this is carries the worst prognosis.
Right.
This is 25% major event.
Yeah. Okay, let's see it.
So we gave him ventricular support. This is the way we puncture, guided by the pigtail. Okay, go ahead.
Femoral access to.
Then we had a femoral TAVR with evoluta, femoral access, and TE echo guidance to be sure at what level of the annulus we were deploying. And a ventricular support device.
Mauricio here. So we didn't discuss surgery. I mean, you mentioned surgery or TAVR. I mean, we never mentioned. So how's your surgeon? Do you have a good surgeon that can do these type of surgeries? You know, he's only 59.
It's only 59, you're sure, Mauricio, but they ran away from him. I'm sorry to say that, but they did not want to touch the patient.
Yeah, and he has severe COPD, and he's also got an ejection fraction of 16%. So I can see why there might be a little reluctance there too.
And since Tony's there, he can dare to do the case, so we took with honor the decision. So we place a ventricular support device. As you can see immediately by the balloon, and this, matter of fact, it is a 22 balloon, you can see where you can implant the valve, just above the level of the pigtail. it shows you by the edge it's making right there. Okay, we didn't occlude the coronaries as a matter of fact with that. So we went down with the valve. This is the echo we were performing. Go ahead again. And this is the implant. You can see it's 1 or 2 millimeters above the level of these non-coronary sinus. Afterward, we obtained this. As you can see with the echo, there's an under-expansion, a severe under-expansion that the calcium at the left coronary level didn't allow us to do at the left coronary sinus. So we went with a 30 millimeter balloon. Next. Okay, that was the expansion. Believe me, that calcium was pretty hard, very difficult. As you can see at the end, it returns a bit. And that's the level we implanted. You can see the valve now completely expanded. Only with the area was 2.3 square centimeters and the mean gradient was 12. So this was the result. With the echo, you can see the valve implanted above the annulus. Any questions or?
And you said you had no perivalvular leak and no major gradient?
No, there is no parallel leak. You can see the echo.
And you did him with ECMO support, and then removed it right after the procedure?
Immediately.
Mm-hmm.
The patient was doing well. Weaned out our anesthesia. He had very good pressures, very good feeling pressures. So he went to his room, he's recovered. Now he's working and doing very well.
Great, beautiful case. Well, we can definitely stretch the limits. Carlos, any comments there?
Yeah, no, I think that the results look great, and the fact that it was a bicuspid really, lets you kind of, I think, treat this in in a supraannular position. Despite the fact that the LVOT, and the annulus was huge. I mean, 1100 is is really a huge annulus. I mean, we've been sitting on a couple of patients in the 900 to 1000 range, until they really develop symptoms. Because of that fear that there's and those are tri-leaflet valves. So I think that the two cases that Sergio and Dr. Dager showed really highlight that nicely. That in the tri-leaflet, valves, I think that you really want to seal at the annulus, and the bicuspids, true bicuspids, like we saw. Maybe we could go a little bit larger. Com to com, and then look at the com to size. Those bicuspids, and maybe get away with a little larger dimensions. So that was great.
Yeah. So, Tony, what's the largest annulus you've treated in aortic insufficiency patients in pure AI?
In pure AI, another bicuspid is 126.
126, but it was a bicuspid. Did it have calcification or it didn't have calcification?
No, this one didn't have any. But what we did it.
Wow. Wonderful. So let's. I mean, I'm having too much fun to make this end, but let's go on to the next case by Sergio.
Yeah. Okay, so this last case of the night is a sweet nonagenarian granny admitted with heart failure symptoms and found to have severe ES, mainly because of age and frailty. She was turned down for surgical options. The echo confirmed the presence of very severe calcific AS and also calcific mitral stenosis in the moderate to severe range, with a mitral valve area of 1.6 and gradients in the 8 to 12 range. She had non-obstructive but diffusely calcified coronary arteries, but non-obstructive coronary artery disease, neither on the left coronary or the right coronary artery. So we proceeded with workup for TAVR, and mainly before we show some sizing, mainly because of this degree and pattern of subannular calcification. We decided to proceed with a self-expandable valve. This, you can see that the coronary heights were normal, the angle was favorable, and once again, you can see the pattern of calcification with some of the calcium extending down to the LVOT. When we looked at it further, we can see some calcium here on the LVOT, concentric calcium, and when we measure the perimeter of the annulus, which is around 63, it goes for a 26 millimeter self-expandable valve. So that's what we planned. The issue though was the axis. So this is the first view of her CT scan. And as you can see, there is diffuse circumferential calcification of the abdominal aorta. And you can see severe chunks of calcium with severe stenosis at the ostium of both iliacs and then at the left common iliac. When we looked at it in further detail, you can see the significant stenosis at the ostium of both iliacs with minimal lumen diameters of around 3 to 4 millimeters on the left and 1 to 5 millimeters depending on the axis that you measure on the right. So when you dig in for alternative access, the subclavians had a minimum diameter at some spots on the right of 5.0, is a 5.0 vessel, and on the left there is a spot where the maximum diameter is around 4.8 centimeters. So maybe not the best option. And we have one of the world pioneers in transcaval access, Dr. O'Neill here. I don't know if he can make any comment, but you can see the calcium on the side of the aorta in relation to the inferior vena cava on the infrarenal aorta. And you can see also that there is some distance of around 1 centimeter between the aorta and the transcaval access. So I'm not sure if this precludes transcaval access, but I guess it definitely makes it a little challenging.
Bill, can you comment on this?
He left.
Bill? Bill, you're not there right this second? No. Okay, good. Well, he'll probably be back in a second. So Tony, have you done trans cables with this type, or have you leave me to?
I'm there.
You're here, but you turned
Very
off.
difficult.
Yeah.
I would think of the procedure that we did a few years, 5 years ago with Andy Kaiser, a go supranavicular. I would like to see the ascending aorta at that time. With this.
Yeah.
Obviously, as a non-engineering, and it's difficult, but transcable with this, it would be very difficult to cross.
Yeah. I mean, I think that we're measuring, that
has more calcium in the aorta than in the bones.
So I'm not sure that we couldn't have gone a little higher, and I would have liked to have seen what Bill thought about that. But let's go on and use what we have here.
Sure. So this is a picture of the aortogram, and you can see again those significant nodules of calcium. And then when we look in more further detail with intravascular ultrasound, you see that in the more stenotic segments, the diameters are around 6 to 4 millimeter. Just as a reminder, this is a 26 millimeter valve, so it's a 14 French sheet. And if you want to use an independent sheet, it's an 18 French system. So you need at least a 5.5 vessel. So I guess we'd already posted this question for the audience, and what we did is we wanted to highlight how the shockwave on intravascular lithotripsy has changed a little bit the field and the practice. So just for the audience, this is a technology that uses acoustic waves to break the intimal and medial calcium, and you can deliver up to 300 cycles per balloon. So that's what we did. This is a 60 by 60 shockwave balloon, and we deliver 300 cycles of energy in those segments. You can see we chose we thought that the left iliac was less diseased than the right, and that's the side that we chose, and we dilated the ostium of the iliac and then into the abdominal aorta, and this is how we advanced that independent sheet, that it actually goes easily. without major challenges. Once we have our independent sheet up there, we were able to continue the case as a routine transcatheter valve replacement. We pre-dilated that valve with an 18mm non-compliant balloon. We position our valve in a cost overlap view. And then we finalize our deployment. You can see here on a coplanar view, you can see our final result, which is a good implant. Maybe like 0 or 1 on the none and 1mm on the left, but you can see complete resolution of the gradients and no AS. And this is a picture of the vessel after we remove the delivery catheter. And on the right, you can see once we have completely sealed our arteriotomy with percloses. So luckily, we didn't have to fix any damage caused by our catheter. And the optimal results of the transcatheter valve were confirmed by echocardiography. She did well and went home a few days later.
Yeah, so a couple of questions here for the panel. Are you all using the shockwave more as a form of access? Tony, I don't know if you have it. You don't have it yet, right?
Not the coronaries, not the peripheral. They're
Yeah.
not
I mean, I don't know what I'd like to comment on of my colleagues because I really think that it's making it almost very difficult to find a case that we have to do any other access with. I just wanted to know your thoughts, Mauricio and Carlos.
One thing too, that you preserve the best access you can have is femoral.
Right.
It's great.
Yeah. Carlos.
Yeah, no, I think that this case highlights that beautifully. I mean, it'd be interesting to see, since the advent of lithotripsy, what's the use of alternative access? To your point, have we started to see decrease in alternative access? Both subclavian, and or carotid, or cable, or some of the other things we've discussed. And I think we are going to see that for that reason you mentioned. I passed the IVUS. What was it, a week or two before this case, and I had my reservations that that it was going to work, because given the severity of that calcium, but the vessels were big enough. So I think the good thing you had here was it was a big vessel. It wasn't a small vessel. These vessels were 1.5 centimeters in diameter. They just had concentric areas of calcium. That you had to just dilate, to be able to get your device across. And once you got across, you weren't going to have an issue with the small, diffusely diseased vessels. So I think the one thing you had going for here that these were really kind of aneurysmal iliacs and the aorta with a lot of calcium. So which is exactly what lithotripsy is supposed to do, right? It's supposed to break up that calcium and make the vessels more compliant. So that was great.
Mauricio?
Thanks, Eddie. Great case. I think shockwave is, it's a very kind of revolutionary technology for the treatment of calcified lesions. The problem is the price. Obviously, these adds about, for peripheral balloon, adds about $2,800 to the cost of the procedure. And the coronary balloons are going to be about $4,000. So maximizing femoral access, I think it's a very important mission. All the other alternative access are associated with other type of complications, and I think it's a great resource to have. I have not had a chance to use it yet, but the only question that I have: do you have to touch that up with a balloon at the end? Do you have to, how do you end up the case? I mean, do you stent it? What would be the vascular outcome of
Yeah.
this?
We normally we haven't had to touch up anything. I mean, that last case obviously still had an angiographically visible. We actually measured gradients in these cases, and they've been good across the stenoses. So I don't think you need to touch them up most of the time, but we were prepared to do that in this particular case, right? Because we left the sheath in until afterwards. By the way, this is a joint case. I think that Mauricio did her cath, Carlos did her IVUS, and she was my patient. They did it for me because we were backed up, and then we discussed it together, and I went ahead and did the procedure with Sergio. So it's that's the best type of team. So we are running out of time, and we have a couple of exhibitors. Giselle, you had a couple of questions you wanted to ask Bill. Unfortunately, he just wrote me that he got called away. So, but you wanted to ask any questions to Igor or the other panelists? Giselle?
Oh, sorry, I was mute. No, I think this has been fascinating. Tony, wow, that's amazing. Those huge valves is just you need to have guts. So that was fascinating, and I know you do a wonderful job down there. But no, it was really more about the AngioVac. I think that will really be, what he presented and vacuum the left appendage. My questions were mostly concerned about the concern of injury, right? Like, and even when he did the mitral valve, I wanted to know if he was concerned about injuring the mitral valve leaflet with it, with the suction and the appendage. He said that he's done 5 cases, but it's such a very thin structure, right? When you see it surgically, it's like a paper thing. So I just wanted to know his thoughts about the concern of injuring.
Yeah, so you're gonna have to write him
Yeah.
that question, because we don't have any experience with it. And I was thinking the same thing when he was doing it, obviously. So Igor, any final thoughts?
No, I think it has been a great meeting, friend. I think that is what the Miami Valve is about. A lot of cutting edge cases and tweaks, and I think
And a
that
lot of friends.
just keep doing it. Just keep doing it.
And a lot of friends, which makes it very fun to do it with. So we're gonna go ahead and I'm gonna just share my screen again. So we left you here. Are you seeing my screen, guys?
Yeah.
Good. So this is the end of tonight's meeting, except for there's going to be an exhibit immediately after this. There will only be a few minutes that we're going to see both an exhibit from Medtronic and an exhibit from Edwards that will allow us to learn some of these concepts that we're talked about here today. Realizing that next Wednesday we continue with Miami Valves at 5 to 7 on the 28th. The 28th will be an evening with Paul Saraja. Many other brilliant panelists will be joining us. On May 5th, there'll be an evening with Atim Latif. The 28th will be mainly mitral. The 5th will be mainly tricuspid, but it'll also have mitral in it. Then on May 12th, Mauricio and Carlos are moderating a complex PCI symposium. It's concentrating specifically on chronic total occlusions. On the 19th, Dr. Mitrani and his group will be hosting Hugh Calkin for a conference on electrophysiology. On the 26th, it'll be a heart failure symposium moderated by Dr. Gosisab and Dr. Grasset. On Saturday, the 22nd, from 8 to 4 will be also a symposium on heart and lung failure and mechanical support, which you all are welcome to join also. So again, as I mentioned to you, next week will be Paul Saraja, 5 to 7. He'll probably only be able to join us from 5 to 6. But remember that at the end of 2021, we're throwing off our mask. And we're going to have a live symposium here in Miami again, in the Miami Marriott Biscayne Bay from February 3rd through the 5th. So thank you all very much. And please stay for our exhibitors to do these 2 little exhibits. So Suresh, I think you're showing the first one, a video from Medtronic. You don't have sound?
From a design built on a proven platform, The Evolute TAVR system delivers what you want for your TAVR cases and your patient's outcomes. The cusp overlap technique brings precision and control to the TAVR procedure by facilitating the ability to accurately assess valve implant depth, which minimizes the risk of interaction with the patient's conduction system. Compared with alternative views, the cusp overlap technique elongates the left ventricular outflow tract, bringing precision to valve implantation by providing a greater visual separation between the basal annular plane and the conduction system. Slow deployment starting at the supraannular level allows the valve to descend to its target position, providing users with control over valve deployment with minimal catheter manipulation. To learn more about the cusp overlap technique, visit Medtronic Academy and contact your local Medtronic representatives.
Wonderful. We've been using the cusp overlap technique now on most cases with core valve. Next person is Jamie Lasang, who's incredible help to us in Edwards, and he'll be taking over the screen.
Thank you, Dr. Marchena. Can you hear me?
Yes.
Hey, I really appreciate y'all staying on for the exhibit hours and fantastic Miami valves as always. It's amazing that now we're 10 years into the SAPIEN valve being on the market. We've almost treated 500,000 patients worldwide. You know, really trying to deliver the outcomes that you demand and really, you know, concentrate on mortality, stroke, PVL similar to TAVR, as well as single digit pacemaker. The SAPIEN 3 Ultra valve, which I know most of y'all are familiar with, does have a new skirt that's 40% higher and is made of a textured PET material, which really has driven our paravalvular leak rates to minimal. So often we concentrate on the implant, but I think really the beauty of the Edwards SAPIEN 3 Ultra system is the commander system as well as the E-sheath, and really that articulation really helps us in these challenging anatomies. And the elegant design of the E-sheath is something that's really beautiful. I know many customers have asked if they can buy this separately for other applications. And really the beauty of TAVR, and you've all talked about this, is we're really trying to have faster procedures, shorter hospital stays, and less rehospitalization. And, you know, when we do have these complications, there are impacts, and that is length of stay to our hospital and our patients. And as you can see here, SAPIEN 3 Ultra has really driven some great results in these areas. We're discharging the majority of our patients. The next day, the majority of them are going home. And really controlling the future. You know, as I joined Edwards 5 years ago, it was really saving patients' lives. Now it's really developing that patient pathway. What are we going to do 10, 15 years down the road? Now we're seeing younger bicuspid patients. We do have bicuspid indication. The commander system really helps us with this challenging anatomy to be able to deliver the SAPIEN 3 Ultra valve where you want it. As you can see here, our SAPIEN 3 Ultra bicuspid.
You know, we're not seeing your screen, Jamie. You're not seeing your.
Oh my, you're not.
No, we're seeing you. You look good.
Oh my gosh. Well, I got a presentation on my screen.
I know, you got to share your screen on the bottom.
I did share.
There you go.
I'm sorry, guys. Well, this is probably really boring for you, but good for me. In the last 6 months, we do have TAVR and TAVR indication, which you would think we would have had, but we do have that as well as valve and valve. And we certainly, in our VIVID registry, seeing great results with our valve and valve. And we're going to certainly see more TAVR and TAVR. And we do see TAVR and TAVR. I think future coronary access is going to really be a relevant topic, and coronary sequestration is a really challenging thought process that we need to think through. We'll also have mitral valve and valve indication. which we are gaining a lot of experience with and having great results with that. Sapien 3 is such an elegantly designed valve. We do have pulmonary indication as well. So I thank everyone for taking the time to come to the exhibit area. I do apologize that you weren't seeing my slides, but thank you very much for your time.
Beautiful. Thank you so much for supporting our meetings. And thank you everybody for staying on, and also for to our great panel. We'll see you all again next Wednesday at 5 o'clock. Thank you.
Thank you.
Thank you.
Hello.